Missed warning signs. Ruptured cerebral aneurysm in a young, healthy woman. This is the case of a 40-year-old female with a relatively unremarkable past medical history who presented to her primary care provider with a headache of 2 weeks duration after a virus which had since resolved. Associated symptoms include dizziness, photosensitivity, and phonophobia, with resistance to over-the-counter treatments such as Mucinex, decongestants, and pain relievers. She admitted she had not been drinking enough water, but denied slurred speech, confusion, weakness, and blurred vision. On exam, she was hemodynamically stable and well-appearing, with equally round and reactive pupils, no focal deficits, and appropriate mood and affect. She was referred to neurology for intractable migraine with status migrainosus, was given a 5-day course of prednisone, and was given strict return precautions to go to the emergency department. Unfortunately, the next day, however, she was unresponsive in her home and was transferred to the emergency department by EMS, where she was found to be tachycardic and mildly hypotensive, unresponsive with a GCS of 3 with fixed and dilated pupils, and she was non-responsive to any stimuli and no reflexes were noted. Subsequent imaging revealed extensive acute subarachnoid hemorrhage and subdural hemorrhage with rightward shift, and neurosurgery consultation deemed this to be a catastrophic injury without any chance for meaningful recovery, and she unfortunately died in the hospital just 2 days later. Now the question that needs to be asked is, could this have been prevented? Were there any warning signs that the primary care provider could have picked on to warrant either stat imaging or immediate referral to the emergency department? In the outpatient setting, when we perform headache evaluations, it first requires differentiating between a primary headache and a secondary headache. A primary headache being one that it is the symptom of itself and can be easily treated, versus a secondary headache where it is the symptom of a secondary underlying pathology that requires further workup and management. It requires performing a detailed, focused headache history and a full, detailed, focused headache physical exam, which includes a full neurological. It requires knowing the right questions to and knowing the red flag signs and symptoms to warrant further management. In the case of this 40-year-old, whether or not they were simply not documented in note from the primary care provider or simply not performed, these are all history and physical exam findings that could have raised warning signals to either get stat imaging or refer to the emergency department, like pain quality and severity, exacerbating factors, whether or not the patient had a history of headaches and migraines. Exam findings such as cranial nerves, motor strength and sensation, reflexes, and fundoscopy. It's also worth noting that a diagnosis of status migrainosus was not an appropriate diagnosis because it requires the patient to have had a history of migraines in the past. In this case, several red flags that could have been picked up if a detailed history and physical exam were performed was the fact that it had lasted 2 weeks with resistance to over-the-counter treatments. It was new onset and a patient without a history of migraine in a former smoker who was age 40 and above. Any one of these warning signs, utilizing the American College of Radiology's appropriateness criteria for head imaging, or immediate referral to the emergency department, could have potentially prevented this tragedy. There are many resources and tools that we can utilize when evaluating patients in the outpatient setting. And it's worth repeating, the purpose of this case is to emphasize the critical importance of performing a full history and physical exam for patients presenting with headache to ensure there is no symptoms concerning for secondary pathology that would warrant immediate imaging or referral to the emergency department. Thank you.